Hello, welcome everyone. Want to take this time to welcome you to the Power in Prevention, Understanding Risks, Prevention, and Early Detection for Breast Cancer. So thank you all for joining us. While you're waiting, we do have a poll that we welcome you to fill out. Also wanted to point out that there will be a live Q&A after the presentation. So I want you to feel free to submit your questions through the Q&A. Now your questions are going to go directly to the panel. Other participants will not see them. So, feel free to ask away. Usually something that you're wondering is something that someone else is wondering too. So definitely feel free to be candid in your questions. You should be seeing the poll now. So please take a moment and answer the couple of questions that we have for you. Okay, we're going to go ahead. So welcome everyone to the Power of Prevention. My name is Felicia Fontaine. I am the Senior Director of Operations here at Sturdy Health. Firstly, I really want to thank you all for being here today. Now, whether you're seeking to enhance your knowledge, your support of a loved one, or just be proactive about your own health, this webinar is for you. Your participation and engagement is welcomed. We will have a poll on the screen. So a lot of you have already seen that, but if you're just seeing it now for the first time, please fill it out and share a little bit about why you're here today. Also going to be question and answer segment at the end of the presentation. This is your opportunity to ask questions. Now, the rest of the group will not be able to see your questions. They're submitted only to the panel, so please do not be shy. Our panel is here to help you, and they're excited to hear from you. Now, today's panel includes 3 exceptional Sturdy Health physicians. We have Dr. Asma Latif, a board-certified medical oncologist and hematologist. She is the director of breast oncology at Sturdy Health. She received her Doctor of Medicine from the University of Kansas School of Medicine, and her clinical practice is dedicated to caring for people with various forms of cancer while specializing in breast gynecologic cancers. And we have Dr. Janice Rothschild. She's a board-certified general surgeon at Sturdy Health. She received her Doctor of Medicine from New York University and completed her residency in general surgery at New England Medical Center, where she was chief resident. Dr. Rothschild finds surgery to be the most satisfying specialty, as she can often diagnose the problem the patient has and have the means of curing it fully. And we have Dr. Jill Saunders. Jill Saunders is a board-certified radiologist with Rhode Island Medical Imaging, working with Sturdy Health. She received her Doctor of Medicine from the University of Massachusetts Medical School, completed her residency at Tufts Medical Center in Boston, and a fellowship in women's imaging at Brigham and Women's Hospital in Boston. Patients describe Dr. Saunders as thorough, caring, and very clear. So now, without further ado, please take it away, Dr. Latif.
Thank you so much, Felicia, for moderating today, and to Molly for hosting the session, and most of all to everybody who's out there listening in and watching. I'm really honored to be here along with Dr. Saunders and Dr. Rothschild as we bring attention to the importance of empowering ourselves to take control of our health and well-being. So as many of you know, aside from skin cancer, breast cancer is the most common cancer diagnosed in women. And 1 in 8 women will develop it over their lifetime. And although, unfortunately, it is so common, we're living through such an amazing period where we have so many advances in awareness, screening, and treatments. And all of these advances have really led to a significant decline in the risk of actually dying from breast cancer. So what that means is nowadays, most people who are diagnosed with breast cancer can be offered curative treatments because of these advances. Although the remainder of this talk really focuses on female breast cancer, I want to take a moment to just highlight that 1 in 100 cases of breast cancer are actually diagnosed in men. And so I want everyone here to tell the men in your life that although they don't typically go for screening mammograms, if they notice any changes in their breast tissue or chest wall tissue, they should absolutely bring that to the attention of their provider. We don't want that to get missed. So next slide, please. So I really want to talk a little bit about risk factors for developing breast cancer. Most women are at average risk, which means that they have a less than 15% lifetime chance of developing breast cancer. But we really need to understand what affects that risk. So, for example, we know that if a woman has had a prior history of breast cancer, or even has, if she's been found to have what's considered a high risk lesion on biopsy, so certain patterns that have been seen on prior breast biopsies that are benign, we still know that those women can be at higher risk for developing a future breast cancer. So that's a big one to pay attention to. In addition to personal history, family history is huge. Having a first degree relative with breast cancer can double one's own risk for developing breast cancer. And although most people who develop breast cancer do not get found to have a genetic change that specifically caused it, some women are found to have inherited specific mutations, such as a BRCA mutation, or there's many other mutations as well that can actually increase the risk of breast and other cancers, and that can even occur at a young age. So it is important to think about genetics anytime we think about our own cancer risk. Other things that can affect risk are exposure to chest radiation at a young age. So for example, if someone is treated for lymphoma at a young age, that's something to think about. If you're told that you have dense breast tissue, that can increase the risk of breast cancer. And even reproductive factors. A lot of these reproductive factors are things that we may not even have control over. So having like this first menstrual period at a younger age, or having your last menstrual period going through menopause at a later age, actually increases the risk of breast cancer. Having fewer or later in life pregnancies can also be associated with an increased risk. These are just a few that I mentioned. There are so many other potential risk factors that have been thought to be associated with the development of breast cancer. But I really want to switch on the next slide to talk about some of the things that we can do to actually modify our risk. So in terms of protective lifestyle modifications, one of the biggest ones is keeping our body weight in the ideal range. Our fat cells make estrogen, and that estrogen circulates throughout the body and can stimulate breast cells. And so we know that an increase in fatty tissue in our body actually can increase our estrogen levels and increase the risk of breast cancer. So anything that can be done to move that body weight down to the ideal range can be beneficial in so many different ways, but especially in terms of decreasing cancer risk. We also think that excess fatty tissue and obesity increases inflammation in the body as well, which is thought to have a role in many different illnesses. So it comes with a lot of different benefits. Movement is so important. So anybody who knows me, who might see me in the office or sees me outside of the clinic, knows that I'm big exercise girl. I think movement is one of the most important things that we can do in all aspects of our health, both mental and physical health. But we have a clear relationship that's been found between the amount of movement someone does on average every week and their breast cancer risk. It seems like that sweet spot is at least 150 minutes or more of exercise actually decreases the breast cancer risk in a measurable way. And that sounds like a lot, but it actually is not that hard. A daily walk, any sort of, active movement, even in the house, if it's bad weather, contributes to that average. Other things that can significantly decrease the risk of breast cancer, minimizing alcohol. So we know that drinking 2 or fewer alcoholic drinks a week has thought to be associated with a lower risk. So really minimizing alcohol, avoiding any smoking, tobacco, or vaping, and trying to stick to a low-fat diet. The diet question has always been tough to answer, but there are some studies that indicate that low-fat diet not only decreases the risk of breast cancer, but also thinking about minimizing red meat, saturated fats, and really focusing on like a Mediterranean-style diet seems to be the most healthy. For women who have the opportunity to breastfeed and may be able to do that, we actually find that that's a protective factor. So there is something about the stimulation of breast cells that in that way that can help protect them from damage in the future. So that can be productive. And for women who are found to be at elevated or high risk of developing breast cancer, sometimes based on their genetics or sometimes based on prior biopsies, we know that there can be preventive medications such as anti-estrogen pills or even preventive surgeries that might be considered. So there's a lot we can do to try to reduce our risk. Next slide, please. The reason we're talking about risk factors for breast cancer is because it's really important to understand one's own specific risk so that we can figure out what the best screening plan is for you. So we now recommend that all women talk to their provider around the age of 25 to really discuss their personal risk factors and then revisit that conversation every few years. And then based on that conversation, a plan can be made about how best to monitor you going forward. So that conversation can actually lead to what many providers have access to right in the office, which is a special type of, it's almost like a computer model where they can input lots of characteristics about you, about your height, your weight, your breast density, all sorts of things. And we can actually estimate, get a percentage of how likely it is to develop breast cancer over the lifetime. These computer models are far from perfect. They're, definitely have flaws, and it's really hard to capture all of the risk with a model like that. But they can be helpful in terms of understanding if you're at higher risk for developing breast cancer than the average population. And then based on that, a personalized screening plan can be designed. So on that note, I'm going to pass it on to our esteemed breast radiologist, Dr. Saunders, so that she can share her knowledge on breast cancer screening and early detection. Thanks, Jill.
Thank you, Dr. Latif, and thank you, Dr. Rothschild, for being here, and thank you, Felicia and Molly, for setting everything up, and of course, thank you to everyone who's here. I'm so glad to have you. So I'm going to move on to breast cancer screening, and just in general, screening mammography has been shown to reduce the breast cancer mortality by 40% in women who are 40 years and older. And I'm going to go over the guidelines, and I am going over specifically the American College of Radiology screening guidelines, which is what I follow as radiologist. So, as Dr. Latif mentioned, when women are about 25 and older,
Jill, I'm sorry to interrupt.
Yeah.
I don't know if you're away from the microphone, or I don't know if it's just me, but
oh, can you not hear me?
Right now I hear you perfectly.
I can get closer to the microphone and talk a little louder.
Thank you so much.
Great. Thank you for letting me know. So yeah, as Dr. Latif mentioned, when women are about 25 and older, we urge you to discuss your risk with your providers to figure out if you fall into that average risk category or if you're possibly at an elevated risk. Women of average risk, we recommend that you begin screening mammography annually when you're 40. Next slide, please. And so what we offer for screening here at Sturdy Health, annual screening mammography for women over 40. So we have tomosynthesis, which you may know as 3D mammography. And that looks at three-dimensional slices of the breast, looks at the different levels of the breast tissue as we're looking through in multiple views on both sides. And then we also offer supplemental screening. And so if women are in elevated risk of breast cancer, so in general, if your lifetime risk is over 20%, and particularly if you have dense breast tissue, we offer supplemental screening breast MRI. And then for women who are of average risk, again, if you have that dense tissue, Or if you're at elevated risk but unable to undergo MRI for whatever reason, we offer supplemental screening breast ultrasound. And so those screening tests are generally performed annually 6 months apart from your mammogram. So you would have breast imaging at twice a year, 6 months apart. Next slide, please. And so I mentioned breast density. So what is breast density? You may have heard this in the news too. There have been some recent updates. So breast tissue is generally made up of a mixture of glandular, fibrous, and fatty tissue. And these different types of tissue appear as different degrees of black, gray, and white on a mammogram, on the X-ray. And so we, as radiologists, report 4 categories, and they're separated as into if the breast tissue is predominantly fatty tissue, and that's about 10% of the population. If the tissue, what we call is scattered areas of fibroglandular density, so that's the next level of density, and that's about 40% of women. And then the next level would be heterogeneously dense, so you're getting a little more density. That's about 40% of women as well. And then the last category is extremely dense tissue, and that's 10% of women have that category. And it's nothing you can control. But why is it important? So when we look at the mammogram, the dense tissue looks white, and that can obscure and look similar to some cancers. And so dense tissue can cause some limitations in the sensitivity of mammography, which is why we report that in reports and women get letters. It can also be an independent risk for developing breast cancer. And so how do you know what your breast density is? When you have a mammogram, the letter is included with your report to give you the personal density of what your breast tissue density is. Next slide, please. And so you may also have heard some barriers to screening. Screening can cause some anxiety, and mammography can be an uncomfortable exam, but it's generally pretty quick. Women can get called back. About 10% of women get called back from their screening studies for additional imaging. And occasionally that leads to a recommendation for biopsy. But most biopsies these days can be performed in the office and are what we call minimally invasive. People may hear of what's called overdiagnosis, and some reports may say that some of these small cancers may never go on to cause harm. And then another barrier some women talk about is radiation. But background radiation that people are naturally exposed to is similar over several months to what you would receive in a mammogram. And science evidence shows that the benefits of screening mammography outweigh the small potential risks. So thank you. And now I will pass along to Dr. Rothschild.
Thank you. So we're going along a scale of prevention and finding things and screening, and this is a little bit more heading into the more active management. I would say that in terms of prevention, everybody talks about breast self-examination, and we encourage women to do self-examination, but I would like you to know that there's been no study that shows that self-examination is actually going to save your life. What it helps with is becoming familiar with what your breast feels like. And that's helpful in 2 ways. First of all, the main thing we want women to do is that if they notice a change, it should be brought to attention. But the other thing is, if you're seeing a new doctor and the person says, "Oh, what's that? I'm worried about that." And you can say, "Oh, that's always there. That's been there for 40 years since I was pregnant." And then, lower the anxiety level, lower the need for any further evaluation. The thing to know is that if you're going to do self-examination, you should do it at the same time of the month on a monthly basis, because your breasts are going to change, as you know, throughout the month. If you're still menstruating, if you're still in that age range. And so you want to be comparing apples to apples instead of apples to oranges. If you do it right before your period and then you do it 2 weeks later, it's going to feel very different. The other thing is also that you don't want to be doing self-examination every day. First of all, that's very anxiety provoking, but it's It's kind of like when you see somebody with a mustache. You don't realize that if you see them every day that they shave their mustache off. If you do something every day, you're just never going to recognize a change. And so once a month, about 2 weeks after you start your period, if you're still menstruating, is a good time. If you're not menstruating yet or past menstruation, pick a day when you pay your rent, first of the month, whatever will remind you to do it, and just become familiar with what's normal for you. And I can pretty much guarantee that if there's a change in your breast, you'll notice it. Now, that doesn't mean that you need to be seen immediately. Some changes in the breast will be just those changes of your cycle. And it's generally fairly safe to wait a cycle or two to see if it goes away. But if you have a persistent change in your breast, then you should bring it to the attention of your doctor. So what are the things that you might notice if you notice a change? Obviously, the first thing is going to be a mass. That might show up as what I usually say is most breasts feel sort of like a bowl of oatmeal. They'll be a little nodular, but a mass will feel like a marble in a bowl of oatmeal. And you'll notice that it's different than what usually feels like. The other thing that you should be aware of is if things look different. When you do your self-examination, first thing you should do is look in the mirror. If you notice that your nipple looks different, if it's kind of poking in instead of poking out, if the skin looks funny or scaly or different or bleeding, or if there's any drainage there. Pain typically is not anything significant to worry about. Most women have some pain during the course of their cycle. But if there's a difference in your pattern of pain, if there's a persistent pain, if it's a specific area, that's something to bear in mind. If there's any skin changes, a rash, thickening, itching, scaling, as I say, those are all things that shouldn't necessarily be there. They may be something as simple as you changed your laundry detergent or you're wearing a new clothing or anything like that. Doesn't necessarily mean that any of these things are of concern or that you have to worry about them, but it does mean that they should be checked out. Next slide. So as I said, if you notice any of these things, other than maybe just a little lumpiness during your cycle, you could give a little bit of time, but you should get attention from somebody. Now, your doctor will probably do an examination, and there may be something else that you need. An examination isn't the most, fingers are not the most sensitive way of looking at things. As Dr. Saunders said, we've got great ways of looking under the skin. A mammogram or an ultrasound will probably be the first thing that's done. Depending on what the mammogram or ultrasound shows, if it shows something that it can explain the change that you're noticing, then we'll probably go ahead to a biopsy. Biopsies have come a long way, as Dr. Saunders mentioned. Doesn't mean that you have to go to the operating room to have a biopsy. Typically, a little bit of Novocaine and a needle can give us a lot of information by getting tissue from the breast. It does, I will tell people who are scheduled for biopsies that it takes a while to get the full report. You'll probably see something in your portal before we have all the information that we need, but it gives us a lot of information about what might or might not need attention. There are lots of results that you can get from a biopsy that aren't cancer. Most of them are not cancer. Most of the things that you're called upon to do a biopsy from a mammogram are not cancer. But sometimes the benign findings also need some attention. And so you go over any of the results with your doctor. If you should be found to have a breast cancer, and most of the time we see these based on the mammogram findings, it's the huge advantage that mammogram and ultrasound and potentially MRI has provided. And you find new cancers, sometimes smaller than you could even feel them. And that's the thing to remember, is that they're small and they're manageable. Most of the time, if you find something on a mammogram, it's, I won't say easily, but it's definitively managed in ways that we can provide, with surgery to remove it, with other parts of the surgery to find out whether or not it has spread anywhere. And typically, we work as a team between Dr. Saunders, Dr. Latif, the radiation folks, and myself. We work as a team to give you the best choices about what you should do, and you certainly have choices. It's not something that we're going to tell you, oh, you have to have this, that, or the other. We discuss the choices and the outcomes that you can expect, and they usually involve surgery, radiation, pills, sometimes other types of medicine. And as Dr. Latif said, these have come a long, long way in managing breast cancer, and often are very curative and can manage the things that we find. Back to Felicia.
Okay, great. Thank you so much. I definitely want to thank you all. Thank you, Dr. Latif, Dr. Saunders, and Dr. Rothschild, for this very helpful information. I know I really did learn a lot. And we do have some questions, so we're going to take advantage of having you here. One common theme of the questions has been surrounding dense breasts. So I'm just going to kind of summarize a few questions together. If I have dense breast, what's the best type of mammogram to follow up with? If I have dense breast noted on a mammogram, what should I do? Should an ultrasound be done?
So I can speak to those. So yes, if you have dense breast tissue, we recommend that you continue with your annual screening mammography, and we offer the state-of-the-art 3D tomosynthesis, and that is what I would recommend. In addition, though, if you wanted to pursue supplemental screening, and if you are of average risk of breast cancer, so less than the 20%, you could have supplemental screening breast ultrasound. And we would recommend that be done 6 months apart from your screening mammogram. If you have an elevated risk of breast cancer greater than 20%, then we would recommend the supplemental screening be done by breast MRI. So those are our current recommendations.
Thank you. That's helpful.
Thanks, Dr. Saunders. I just want to add one quick thing, because I'm not surprised to hear that there are many people out there with questions about dense breast tissue. It comes up so much, everybody's being informed of their breast density, but in the letters, it doesn't always tell you what to do, because it really is a conversation. And so it's so important to have that conversation. If it's my patients, if I'm already seeing, if you're already seeing a breast oncologist, of course, we expect to have those conversations, but you can bring it up with whichever provider is in charge of your breast screening, because you want to make sure that the pros and cons are discussed, and make sure that this is addressed. It's not something that's, ignored either. So, especially when we have such good tests with ultrasounds and MRIs to be able to really get good looks.
Thank you, Dr. Latif. Okay, we have another question. Should you still have any pain in your breast after menopause?
The simple answer to that is there's still estrogen in your body, so you definitely can have pain, and I see many older women who still have pain. The most common causes for pain are a combination of hormones and diet. And there are a number of things in your diet that can exacerbate pain. I usually group these as coffee, tea, cola, and chocolate. Not the caffeine, so switching to decaf isn't really going to be helpful. But the bottom line is that if you're still drinking coffee at age 75 and you still have some estrogen in your body, you certainly can still have pain.
Thank you. So let's move on to a breastfeeding question. Can I continue to breastfeed while having radiation therapy?
That's tough. So I think it really depends on the location of the radiation treatment. In general, if it is a pregnancy-associated breast cancer and radiation is to that breast, then my understanding is that typically it's not recommended. But I want to qualify my answer that I think I would have to review like the most current guidelines. If that person who had that question, wants to reach out to me separately, I would be happy to look into it further, because I think we have such a small amount of data of people who are going through that. In terms of pregnancy and breast cancer in general, we know that, during pregnancy, people can have surgery. During pregnancy, people can even receive chemotherapy, like later on in pregnancy during the second and third trimesters. But specifically during pregnancy, radiation is never given. And so I think it would be a little bit more of a complicated.
So maybe on a case by case basis to review.
Yeah, definitely would want this person to discuss, of course, with their radiation oncologist. I think to see if that's beneficial. Sometimes there are other ways to try to maintain like milk production, even if someone is not directly nursing or breastfeeding. But I think even then there would have to be discussion about what to do with the milk.
Thank you, Dr. Latif. All right, next question. With all the screening and testing available, why hasn't the percentage decreased for women developing breast cancer? Are there environmental factors?
Yeah, that's a good question. So the screening and all of the methods for early detection, so, clinical examinations like with your provider, ultrasound, mammogram, MRIs, none of those can actually prevent breast cancer. Those are really tools to help pick up a breast cancer at a curable stage. So when it's really small, ideally, so that it can be treated to the full extent and that person can live a natural life. In terms of bringing down the numbers of actual diagnoses, and preventing breast cancer, I absolutely agree that I think there are probably so many factors. We talked a little bit about the personal factors, including diet and substances that we use, but and that can be even things that are in our food, things that are in our water. We have an epidemic of obesity, so there's so many other factors that are contributing, that I think that's one of the reasons we're not seeing a decline in the actual rates or incidence of breast cancer. And a lot of the things that are discussed in terms of healthy lifestyle and well-being and wellness, like diet, exercise, going for those whole foods, minimizing exposures to chemicals that we can avoid, all of that is going to be beneficial, not just to reduce the risk of breast cancer, but probably a lot of medical problems. But, unfortunately, the screening methods, they can't prevent the cancer directly.
That makes sense.
Yeah.
Okay, next question. If you have a family history of breast cancer, what is the criteria for early screening? Is it related to the family member being diagnosed pre or post-menopausal?
I can take that one. So generally, when we talk about a family history, it's talking about a premenopausal diagnosis of cancer. And current guidelines recommend that screening would begin 10 years before that diagnosis in that first degree relative. So mother, grandmother, but not before age 30 to start screening mammography. For other elevated risks, if there's a known genetic mutation, then some guidelines recommend screening breast MRI starting as early as 25. And it's really something, as Dr. Latif said, to talk with your provider if you think you're of increased risk, to get the risk assessment and see exactly where you fall and what the risk factor is. So that was a good question.
Does the breast that had radiation look different under mammogram or MRI than it did before?
Yes. Whenever when someone has had treatment for breast cancer, surgery, and radiation, there are changes that are pretty classic that we see. And so we know and expect those changes when you have your first mammogram after surgery, but it's not uncommon for us to say, come back sooner, maybe in 6 months rather than a year, if we want to keep an extra eye on that. So, yes.
Excellent. Thank you. Dr. Rothschild, this one might be for you. When it comes to surgery, what is the recovery like? How long will I be in the hospital? When can I go back to work and normal activities?
So of course, that's going to depend on what operation you have. If a woman has a lumpectomy, just removing a bit of tissue, whether it's for a biopsy or a cancer diagnosis, most people can go back to work within a day or two. Bruising is very, very common, but there's not much in the way of limitation. All those procedures are done as outpatients between getting ready for surgery, the recovery. It's usually about a half a day. If you add surgery to a lumpectomy for checking the lymph nodes, that's actually a lot more uncomfortable and more to recover from. But even so, it takes about a week to two until you're feeling close to normal. If you have a mastectomy with reconstruction, then that's a completely different story. And that's going on more like 1 to 2 months of recovery.
Thank you. That's helpful. Okay, and this is our last question. I think actually one more might have been added. Do anti-estrogen medications cause hair loss, and can anything be done for that?
This is one of the questions that comes up the most for me, and in clinic at least. You know, as we all know, as we mature, our hair naturally thins already. So most of us are already dealing with that. And it is true that anti-estrogen medications or estrogen blockers, this could be anastrozole, letrozole, or exemestane, or even tamoxifen, can impact the thickness of our hair. Oftentimes, especially those first three medications I mentioned, accentuate the side effects of or the symptoms of menopause. And so some women more than others may experience hair thinning or hair loss. When this comes up, one of the most important things is to first make sure there's nothing else that's going on. So sometimes a significant stressor in the life can actually cause hair loss or medical issue. Checking like the thyroid function, some vitamin levels as well is often appropriate, just to make sure there's not that the hair loss is not a symptom of something else. Oftentimes, women will end up meeting with a dermatologist to talk about options. We do know there is some recent data that specifically for women who are on anti-estrogens using essentially like a men's Rogaine, like a topical, can be beneficial, but it requires use over many months to see an improvement. And so that is something that can absolutely be considered. There are other supplements that women will ask about often, like biotin for hair and nails. And although certainly I have women who will tell me that they are on it and it's helped and we're happy that's the case, I'm not aware that there's any proven benefit of those sorts of supplements. And I mentioned that because sometimes these supplements can be quite costly and have other effects. So there absolutely are potential connections between anti-estrogens and hair thinning, but there are some potential options as well to try to help minimize that.
But I want to clarify something because sometimes patients are not clear. Chemotherapy is known to cause hair loss. And the hormone treatments the anti-hormone treatments that you get after treatment for breast cancer are not that. And even with chemotherapy, there are ways to prevent hair loss. But when you talk about complete hair loss, you're talking about chemotherapy, not the medications that Dr. Latif was talking about.
Correct. Yes, absolutely. So the anti-estrogen medications do not cause people to go bald. It's if anything, it's like a thinning. And just like Dr. Rothschild mentioned, chemotherapy can certainly lead to full hair loss temporarily. But now we have really great ways where we can actually try to minimize the chance of even going bald with chemo.
Wow, that's very helpful. Thank you. Okay, we have another question. I have a friend that went through radiation and had minor radiation burn. What percentage of patients experience this, and how is it best treated and or prevented?
I can speak to this, and Jan, if you want to speak a little bit as well, you're welcome. So, in general, I think it's not a very common thing to see any significant burning during radiation, but just like the way the radiation is working, it is burning the cells in a way. Oftentimes, women will have like almost like a mild sunburn, or certainly tanner, more hyperpigmented skin, and rarely like skin peeling and blistering. During the actual course of radiation, there are really strict guidelines from the radiation oncologist and their team about what creams and things like that to use, because we don't want it to interfere with the treatment itself. But generally, they will recommend kind of like thick emollients like Aquaphor and other kind of thick creams afterwards to try to provide a barrier and kind of get that moisture back into the breast. Dr. Rothschild, anything you want to add? Because I know sometimes you do this as well.
I would just highlight that a little bit. It's 100% that you'll get skin changes with radiation, because that's what it does. It's like getting an X-ray every day, and it's like getting a sunburn. So everybody will get at least a mild sunburn. A very small percentage will have a bothersome skin change that needs intervention.
Okay, I think that might wrap up our questions. So definitely big thank you all. But before we go, I think Molly might have had the poll results to share with us. And so let's see. The average, they came in so quick. So let's see. We answered 54% of our respondents thought it was 9% for the risk of developing breast cancer, and 39% did get that correct answer of the 13%. And then this one really surprised me, and I think it surprised our respondents too. So 8% of our respondents said 14. We had 46 who said 29%, 38 said 42, and only 8% got it correct. 59% report that they are not staying on track with their annual mammograms. So I think big thank you to the esteemed panel for being here, for answering our questions and informing us and raising awareness during Breast Cancer Awareness Month. But a takeaway for all of us is to please get your mammogram, or remind your loved ones to get their mammogram. They do matter, and early prevention can save lives. So thank you all.
Thank you.
Thank you.
Thanks, everybody.
Bye-bye.